Hello, everyone. Thanks very much for the opportunity to speak today at your virtual conference. Before I get my slides up, I'd just like to, well, thank you for the opportunity, but also thanks to Sue Millman for both being an excellent vice chair of the board at Genetic Alliance UK and for all the help and forceful advocacy she's putting in on the topic that I'm about to talk about today. So I'll get my slides going here. Sue's given me the challenging task of talking about quite a big, broad topic in 10 to 15 minutes. And I suppose I'm handing over that tough challenge to Sue because I'm not going to be around for questions after this. But to kick off, uh, we can't do any of our work without the support of our members and for all of our members' communities that share their stories. So thanks to all of you, thanks to all of our members. We'll be able to share the slides after this and you can see all of our declarations of interest and so on there. So Genetic Alliance UK is the national alliance for everyone living with genetic, rare and undiagnosed conditions. We've got more than 240 members now. We're quite a small team, but with our members, hopefully we have quite a big impact. We run the Rare Disease UK campaign, which is focused on renewing the UK Rare Diseases Framework. We also run the annual Celebration and Awareness Day, Rare Disease Day, and we run a support network for families with children with undiagnosed conditions. So to leap into the topic today, I'm going to talk about which bits of the system we're talking about and try to give a bit of an overview of that system. And then kind of look at this through the lens of what our community are facing, and then talk about what we can and are doing about it. So let's start with a flowchart. And this is a key part of the flowchart for getting new innovative treatments to people that need them. So on the left, we have market authorization, where there's a decision about whether or not the technology is both safe and does what the company or the sponsor says it does. So this is really to protect us as a population. The next phase is deciding whether or not the treatment is worth spending the government's money on. So is the amount of benefit that the medicine is giving worth the cost that it has to the health service? And then the third key bit is actually getting that treatment to people within a very complex healthcare system. And we call these stages lots of different things. I'm going to try and be disciplined, but market authorization, sometimes we call that a licensing decision. These decisions are made by a set of agencies we have in the UK, and the MHRA is the one that protects us and makes announcements about the safety of medicines and so on. Then you'll have heard of NICE probably, which makes the cost effectiveness decision, carries out HTA, Health Technology Appraisal, for England, and that decision then applies in Wales and Northern Ireland. Scotland has its own independent system called the SMC, Scottish Medicines Consortium. And then there are NHSs in all four nations, and they're structured in quite complex ways. So let's be clear, this is simplification, and it's part of a much bigger system. This market authorization phase is not the first bit of the process, and there's a lot of hard work that goes into getting to that stage. And this NHS delivery side of things is much more complicated and detailed. And when we talk about a care pathway, we're talking about how you find people that need the treatment using diagnosis techniques or screening, how you get from your GP to the person who can actually help you or diagnose you or provide you with the treatment, how those are organized, those centers are organized in the NHS. And then once we've established that someone has a rare condition and is in need of treatment and hopefully delivered that treatment, how do we keep that excellent care going? All of that's very complicated. I'm going to focus on this kind of simplified middle bit today. Um, this is a picture of an all-party parliamentary group meeting. Genetic Alliance UK is the secretariat for the all-party parliamentary group on genetic rare and undiagnosed conditions, and that brings together politicians from across the political spectrum to work for our community and hopefully have some influence. So this is an opportunity for us to go and talk to parliamentarians. And this is not the meeting that Sue recently joined us at to talk about access issues for your community, but it is an example of what the room looks like. And everyone's paying close attention there, which is not always the case in all party parliamentary group meetings, but we have hopefully a lively atmosphere in ours. We recently had this meeting and we took 6 cases to politicians, and we followed up with some letters from that. So I thought I could talk you through the 6 cases that we took to this meeting. Before I do that, I just need to complicate my simplified slide by explaining that this process takes time. So it takes time to get both of these decisions signed off. And this can be, it's not going to be quicker than 9 months in total and can be over a year. So there are ways that a really valuable treatment can get to people who need it in the NHS quicker. The kind of government-sponsored process with a lot of structure around it is called the Early Access to Medicine Scheme, which starts from before the safety and efficacy decision. But there are other ways that can come that companies can give away the medicine in the NHS. That's always with the company paying for the medicine. So having overcomplicated my simplified process, I'll start with the first 3 examples we've got. So Duchenne muscular dystrophy has a treatment, and I'm not going to mention any of the medicines today. I'm just going to talk about who's getting what medicine. There's a treatment that's conditionally approved, but is still going through NICE for Duchenne muscular dystrophy. The community have managed to find a way to get the company to give this medicine for free in the NHS. Unfortunately, even with the medicine being free, it has been difficult for that community to persuade the hospitals and the trusts to deliver that medicine. Obviously, it has costs to actually process the delivery and so on, and that is not solved. Duchenne UK and Muscular Dystrophy UK are going around the country persuading local areas to deliver this medicine. So there's that challenge there. You'll be familiar with the access challenge for Friedreich's ataxia, and I'll leave that to Sue to discuss. But that appraisal did not go through NICE. And for all of these cases, you see access happening in other countries around Europe. For motor neurone disease, there's a treatment going through NICE that also has an early access program. But again, hospitals aren't delivering this treatment to everyone that needs it. They additionally have a problem that the genetic test to deliver their treatment currently takes a long time, and the progression of the condition is too rapid for that to be an acceptable timeline. The other 3 cases that we took there, a treatment for Niemann-Pick disease was appraised by NICE and not approved. Niemann-Pick UK count 50 countries that are providing access to this treatment. There is a compassionate use scheme that's still in existence, but it doesn't apply to new patients. And NPQ UK are running a Life is Rare campaign highlighting some of the challenges they face. These other 2 are kind of parallel to the pathway I showed you. So the treatment for cystinosis that Metabolic Support UK and Cystinosis UK are trying to get access to is stuck in a NICE an NHS England decision-making process. And Hyperinsulinism UK have a device that they would love to be able to use that's available for people with diabetes, but they can't persuade the NHS to support it. So this is, sorry for the kind of, this isn't probably very clear, but Duchenne and motor neurone are up here. And Friedreich's ataxia, Niemann-Pick are stuck in this area, and cystinosis and hyperinsulinism are stuck here. So there's a kind of a hotspot to the right of this graph, which means a lot of our focus is on, and this is now just a blurry slide, but a lot of our focus is now on NICE and the Scottish Medicines Consortium. Um, so what are the problems that we're facing? What are the components of the challenge? A big part of it is money. Um, we've always paid less than most other countries for medicines in the UK. And that's because we've been able to leverage some of the positivities about the UK, that we've been part of Europe, that NICE is a world-renowned brand. And if you get an approval from NICE, you can take that message to other countries. That the NHS is integrated, we've got a single health service. And that ideally, if we could get this right, has a lot of data potential that companies have been able to leverage for lower costs in the past. And then we've got an excellent workforce and academia around here. This balance seems to be breaking down because we're seeing the signal now of failures for our community. And in the news, there's a big thing about this voluntary scheme for branded medicines pricing, access, and growth, which we call VPAG, which is a big kind of government cap on how much money they're willing to spend per year on medicines. And then Donald Trump has also entered the fray with his message that America should be paying similar prices to other countries around the world. And the global farmers' response to that has been, well, we should probably try to get the rest of the world to pay more so we don't have to lower our prices in America. That's ongoing. Maybe Donald Trump will get distracted. We don't know. And that kind of money situation is really kind of a higher level debate than we can influence particularly. If the government can get medicines cheaply, that's great. If companies can secure their global companies' approval to deliver the medicine, that's great. We just need these deals to be made. But then the cost effectiveness decision, that's got a lot of complexity to it that we are working hard on trying to bring the rare case to. So I won't go through these kind of jargony things, and Sue can take questions on these. But there's various aspects to the NICE decision-making process that puts pressure on rare treatments. We have got some flexibility in this space, and that's because of the campaigning that we've been doing as a community for the past 10 years or so. And that's why I put culture and people on this slide as well, because the tools are there for committee members to use to make flexible decisions around access to treatments at NICE. But they do actually have to choose to use them. The committee members need to do that. So we want to look at some of the culture around NICE as well, whether there's an over-reliance on the health economists that sit around the table that are really kind of number orientated rather than orientated around the experiences of people, that they have quite a strong influence over the whole committee, and that quite a few of them aren't willing to really engage with the challenges that our community face. So what we're doing, we Genetic Alliance UK represent our community in the Charity and Medicines Access Coalition. So we've put forward a statement that I'm hoping we'll be able to publish soon, which essentially says to the ABPI, that's the pharmaceutical industry, and the Department of Health and Social Care, can you please get a decision made and stop this being a barrier to access in our sector? We'd also like them to have, they've both got stats on the environment. If they could actually be saying similar things, that would help our community understand what's happening. But currently they're both presenting the same picture with different stats, which is quite frustrating for us. As I say, we've got our all-party parliamentary group activity, and we have another meeting coming up where we're hoping Ataxia UK will be able to come and give us an update on where campaigning for access to treatments for Friedreich's ataxia is. And ideally, we can be the overarching voice with parallel campaigning happening on a condition by condition basis. And we're building a project to shine a light on this culture and people issue um, at uh, at some of the decision makers. So we'll be bringing some of those messages back to our members and seeking endorsement of that, as well as looking for your engagement, ultimately leading to a call for change. There's going to be a new CEO at NICE soon, so we can get that ready for their arrival. And then lastly, this is my last point, we see the problems in the middle here around the health technology appraisal. That's because medicines are getting into the system. The question is how many medicines, potential treatments for the future, aren't getting into the system because of a high bar at this beginning of my simplified pathway? How many things are getting stuck in the green bit of this pathway? So the Medicines Healthcare Products Regulatory Agency is also actively working on that. Sue's involved in that too, and that's actually we're looking forward to when they give us a statement that we can share that says more specifically what we're working on. But ultimately, it's about lowering that barrier, and we're working on that too. So that should get more through this pathway. I'm going to stop there and say thank you. I wish you a very good conference, and over to Sue for hopefully some interesting questions. Thanks.